Well, hello everyone and good morning. It's the second day of Year 3 PPT for academic year 2023 to 2024. It's welcome from me, and it's also welcome from Richard, who's
Hi.
there. So it's Richard. We're going to put some music on now, which you can listen to, and we'll be back in 15 minutes to start the teaching. So if you're watching this on catch up or replay, then jump forward 15 minutes from this point to the start of the actual teaching phase. Okay, guys, see you later.
The dreams. The dreams.
Well, good morning, everyone. It's nice to see you coming in to join us this morning. I hope you can hear us perfectly well. If there's anything to do with audio glitches, then please let us know. We were streaming yesterday to year 4, touch wood without any major glitches, because obviously we cut our teeth with you guys on Tuesday. Every year when I try and get this running, despite multiple dry runs, there's always some glitch like that with the audio, but hopefully we've got it a bit better this time. If there is any problems, come in on the chat stream and do tell us. And also remember, at any point during today, you can ask questions. So please do come in and ask. today there's just the two of us. Eleanor's got other things to do. So there's Richard and myself. Richard's going to take a bit more of a lead today on this. Not that it's not. He's going to take a bit more of a lead this afternoon. There it was. I was about to launch you into anxiety disorders, Richard, but in fact, you're going to take a bit more of a lead on the AKI and the kidney stuff, which is this afternoon after lunch. So without much more ado, what we're going to do is embark on Block 33, Masterclass 1, Anxiety Disorders, Acute Behavioural Disturbances, and Drug Dependence. The one thing I would say about Block 33 is there is not quite the huge number of different classes of drugs in the mental health block. So we use some of the master classes in the mental health block, particularly Masterclass 3 and Masterclass 4, to touch on some generic pharmacology topics. But of course, we'll be doing that particular masterclass on the morning of the 15th of September because we couldn't fit it all in this week, particularly with there being a bank holiday Monday. If there hadn't been a bank holiday Monday in England, we would have been able to get it all done this week. But I was told you guys needed a bank holiday. So let's get going. Richard, let's start, shall we?
Yep.
So outcomes are here. Again, I won't read through these, so let's just jump straight in and talk about John. Now, John is a 36-year-old paramedic who has a history of episodic palpitations. I'm sitting on John's head. Just notice I'm sitting on his head. I'm going to move. I'm going to come over here. There we are, so you can see John better. So John's 36-year-old paramedic, history of episodic palpitations, sweating and dizziness. He has a background of work-related stress because he had to attend a very traumatic accident where somebody died. And he's now got a deteriorating sleep pattern, poor concentration, lethargy and irritability. He's not on any regular medication and says he has no allergies. So what I'd like you to do initially, I know a lot of you are not in mental health block at the moment. You're still just getting started into year 3, but let's just use some first principles from PBL and think what kind of diagnoses could explain John's presentation. Could you list 3 potential differential diagnoses? So let's see if you're awake. Come in on the chat stream and just post in your ideas. Again, much to Eleanor's upset, the slides are on Blackboard in block 33. So if you've downloaded them, you can flick forward, but I trust you. I trust you to use your heads instead. So do come in and let me know what you think. Going very quiet there. We're all very quiet waiting. Let's see. Generalized anxiety disorder. MR. Yeah, good. That's one. GAD. GAD. PTSD. Yeah, I think Lewis, that seems reasonable. Panic disorder. Absolutely. Yep. I think those are good. Let's have a look and see what we thought. Oh, how weird. There we are. Did you notice that? I've got poor editing on my side. It's got diagnoses there. And when I click on the next one to bring it up, it turns to diagnosis.
Right.
I don't know which is the right term. Anyway. So we thought GAD, perhaps acute stress disorder, and post-traumatic stress disorder. Yeah. I think panic disorder, very similar, isn't it? Acute stress disorder. Absolutely. Let's have a chat about general anxiety disorder. So if you think about general anxiety disorder and you think about the first principles of what may be going on at a sort of a physiological and psychological level with GAD, what kind of pharmacological treatments might one think about? What classes of drugs do you think might be useful in this situation? Remember that it's associated with a lot of somatic symptoms. So come in the chat and let me know what you think. I have been running these at ultra low latency, so hopefully there's not too much of a delay. Yeah, so MR and SSRI. So MR, what makes you particularly choose SSRI? What I'm meaning is you're choosing basically what is a very common antidepressant, modern antidepressant therapy. So how do you think that's going to benefit the GAD? You know, what's your hypothesis? Any ideas? Don't worry. You know, just throw something in. And Lewis said increased levels of serotonin. Okay, yeah. And Lewis said beta blockers to lower heart rate and reduce palpitations and experience of panic. Okay, so Lewis, you're going for sort of a symptomatic therapy, and MR's going for SSRI, which is obviously the neuropharmacological therapy of choice in GAD. Absolutely. Let's have a little look. In the slides, when you go to the slides, you go into the notes section. A lot of these slides in the notes section, we've actually annotated to give you stuff from textbooks to help you and explain it. So in GAD, I mean, obviously we tend to use SSRIs. You can also use SNRIs. So they will also work. And basically, from clinical trial basis, the SSRIs and the SNRIs offer the best efficacy in basically treating GAD with the least risk of side effects. Nobody I noticed has said benzodiazepines, because obviously you could think if somebody's got a lot of anxiety, let's give basically what is a depressant drug in the sense of benzodiazepine, calm them down. But the problem with benzodiazepines, of course, is they're actually quite addictive and they're very difficult to get people off, aren't they, Richard?
Mm.
Yeah. So if you go in there, it depends if it's. I mean, GAD tends to be a much longer term problem. If you had acute stress disorder, then maybe a benzodiazepine, and for a very short, well defined period of time, maybe a week, for an acute stress disorder as an immediate reaction to an event might be something that would be beneficial. But really, I think no longer than a week is usually what's recommended. So if it's the first episode, and this is from the national guidelines, then you should consider prescribing an SSRI, which is what MR had said. And in fact, according to the last time I looked, it was sertraline as the first line choice according to NICE. Alternatives are escitalopram. You see, I can't pronounce names. Escitalopram. Is that right, Richard?
Yeah, that's how I pronounce it.
Yeah, escitalopram. Yeah, or I can pronounce paroxetine. I'm presuming this is derived from evidence base and experience. Do you know, Richard, why it's particularly sertraline? Again, we are not psychiatrists, so we're pharmacologists, really. Sertraline, why do psychiatrists prefer sertraline, do you think?
I mean, they seem to suggest, don't they, that the SSRIs have slightly different effects, don't they? So, like for example, the paroxetine it's got a heavier anticholinergic burden, doesn't it? And is more sedating, and that's why it's generally more avoided. But I suppose in an anxiety disorder, you might want that to some extent. So I suppose that's maybe why paroxetine is there. It seems to be that psychiatrists quite like sertraline, especially in younger patients, don't they?
Yes.
It's really particularly effective in that group, but obviously is associated with, at least in depression, with a slightly increased risk of suicide in the first few weeks, which obviously you need to be aware of and discuss with your patients.
Yeah, I'm just trying to pull up the BNF here. I'm struggling to pull up the BNF. I will come back to that in a second. Sorry, guys, I was trying to get the BNF to come up on my screen there. And I don't quite know why it's not coming up. It's how odd. So, well, I'll fiddle with that in a second. Let's just move on to the next bit. Yeah. So I think that's a good explanation, Richard. So for acute stress disorder, which can also include PTSD, in reality, the best way to manage this is with non-pharmacological approaches initially. So basically, it's counseling. And I think it's important to recognize that within mental health environment, there are many of the therapies do not require drugs. And I think we have this emphasis, or we feel that we have an emphasis always on pharmacological treatments because we're a pharmacologist and you're doing therapeutics. But in reality, it is often in mental health. You need to think about alternative non-pharmacological treatments. You think that's fair, Richard?
Yeah, definitely. I mean, how I always explain it to the patients is that, the medication can be sort of an aid and a bridge to helping the patient work through their problems, but it's not going to do it itself. And so therefore I always try and put it across that the mainstay is the psychological therapy, and the medication is an adjunct to help the patient get the most out of the therapy.
Absolutely. Now, you can consider pharmacotherapy if such as an antidepressant. And again, here we're suggesting paroxetine or maybe mirtazapine. If this person declines referral to psychological services, or if that referral is significantly delayed because maybe there's a year's waiting list, or if the patient just says, I'd rather take some drugs, why not give them the patient choice in this situation? And if they're having difficulty sleeping, then consider things like sleep hygiene. And you may, for very, very short-term use, consider a hypnotic. That could be either something like, suppose it could be temazepam, but more likely one of the Z drugs, maybe zopiclone or zolpidem. What do you think about sleep hygiene? Just chat for a second while I try and get this BNF up, Richard, to talk to the students a bit about sleep hygiene.
Yeah, sure. Well, I'll just quickly mention something about mirtazapine as well. So, as you probably know, mirtazapine's taken at night, and it does have a sedating effect. So it can be quite useful in that way to give a little bit of a hypnotic effect. And in patients who aren't eating, it stimulates appetite as well. So that can be particularly useful in the elderly patients with sort of depression and anxiety. It can be helpful for them. I suppose in terms of sleep hygiene, I suppose it's easy for people to get into dysfunctional spirals, isn't it, where they don't sleep during the night because they're lying there ruminating on thoughts, and then they doze during the day on and off and then can't sleep at night again. So it's trying to give them a bit of structure to avoid that spiral and get back into a regular pattern of going to bed at good times, just helping their function in general, really.
It's reorganizing us a little bit there.
Yeah, it's working now, which is nice.
Yeah, I don't know why it wasn't. It's just, hey, if that's our glitch for the day. That's our glitch, so that's okay. So I was just going to have a quick look at the BNF. Interestingly, if you the way you can search for things in the BNF isn't always very helpful. So if I type in generalized anxiety disorder into the search bar and I press enter, the BNF, if there isn't an immediate treatment summary with that title, it will pull up the drugs. And I'm not quite sure about the order of these, but it's interesting. It is pulling up escitalopram, which was our sort of second line drug, is pulling up duloxetine, which is an SNRI, and it's pulling up paroxetine again.
Oh, yeah, and you've got pregabalin down there.
Yeah,
as well,
interestingly, pregabalin. Although I'm not sure I would be giving pregabalin.
yeah. So it is licensed.
This license, I
actually.
know it is, but I just
Yeah.
not. Gabapentin and pregabalin are now drugs of abuse, aren't they?
Yeah.
So they're also covered by elements of the what's the law? It's the drugs of abuse law, isn't it? What's it called? Anyway, they're classified now. So I have to say I tend to try and avoid them and use alternatives. But yes, it is licensed in that situation. And you can see that they are coming up in for generalized anxiety disorder. So let's just have a look at escitalopram. And you can see here, it gives you, whether it's depressive illness, GAD, or obsessive compulsive disorder, it's talking about the dosing range. Now, you don't have to memorize these doses. In fact, you don't even need to need these doses in year 5, because we don't ask about doses in your final exams. So that's fine. And then for things like panic disorder, again, it's very similar dosing schedule. I think the thing to note with all of these is, if you're elderly, then you start at a much lower dose. You start at half the dose, and you can increase up to half of the maximum dose in a younger person. So we'll go back to this page and we'll carry on. So I'm glad I got my BNF working. So let's just talk a bit about the mode of action of SSRIs. I always found neuropharmacology very complicated. I think it's difficult. I think the problem with the brain is lots of different neurotransmitters do different things in different parts of the brain. So in one part of the brain, they can be inhibitory. Another part of the brain, they can be stimulatory. I think it is interesting. So this is a diagram taken from Rang and Dale's pharmacology. So I know broadly speaking, we think about the serotonin uptake inhibitors to increase serotonin levels, and they do. But what's interesting is, of course, normally what happens is that, as you can see here, I'll get my little pen out, see if I can get it working.
Oh, sorry, I've just noticed MR's written, what is the reason for prescribing an SNRI instead of an SSRI? I understand the antimuscarinic side effects can be worse for an SNRI.
I suspect, MR, that the honest truth that is probably doctor preference from experience. I think most people, to be honest, would probably go for an SSRI, but obviously when you think about the licensing, the drugs are all tested and have undergone clinical trials in this situation to have a license and a recommendation in the BNF. So from that perspective, they can be used. We try and tell you about all the drugs that could potentially be used that are relatively common. We won't necessarily tell you about some massively rare drug that's virtually never ever used in that situation, because it just fills your brain full of useless facts. So we just give you the option. And like in most scenarios, it might be a patient just says, no, I've been on that before, I didn't respond to it, I didn't like it. So you need a secondary option to go to, and that's maybe why you might go for an SNRI. What would you think, Richard?
Well, yeah, I mean, interesting what you bring up, because going back to the sort of genomics, pharmacogenomics, this is particularly relevant in psychiatry, isn't it? So at the moment, we don't really know who's going to respond to which SSRI or if they need an SNRI, and it's all a little bit of a guess, an educated guess. But yeah, possibly, in 10, 15 years' time, we'll be doing a gene panel on every patient that presents with severe anxiety or depression, and we'll work out from that who's going to be the one who responds to the SNRI better, or who is better with paroxetine versus sertraline, or as it is, unfortunately, we have to continue them for at least 6 weeks work out if it's working or not, and then consider a switch, which takes about a month, and it's definitely not optimal yet.
So, I mean, what I was going to show in this slide, I've got my pen working. If you look at this one here, you can see the reuptake of the serotonin, the 5-hydroxytryptamine, serotonin coming back, so that it has a limited period of time at the end plate. When you give acute treatment with an SSRI, of course you block it as shown here, and therefore there is an increase in serotonin at the end plate here. But of course, what you then get is less serotonin initially, and you get slightly less nerve impulsation. So there are some people think this may be one of the explanations why initially some patients may worsen in the early stages of treatment with an SSRI for depression. But once you've been on it for a period of time, the levels of serotonin significantly increase at the junction, and you get increased impulsation down the stimulatory nerves, hopefully improving your depression. I think that's the theory, isn't it, Richard, from my reading and understanding of the situation?
Yeah, it's not something I'm particularly au fait with, but that's my understanding.
Yeah, because you just got to think, because it's the chronic therapy that works. Because again, we'll come to this in a minute. The reality is that SSRIs don't work immediately. In fact, no antidepressant drug works immediately. So let's look at some of the common side effects. You can't memorize every single side effect for SSRIs, but clearly the side effects which are common I've listed here, or which are what we might call red flag. And particularly, just to note that they can, in some people, prolong the QT interval. And also, particularly in the elderly, they can precipitate hyponatremia. But this is not a common side effect, but it's an important one. The other things to think about, you have got this risk of serotonin syndrome, particularly where there might be a drug-drug interaction with another drug that increases serotonin levels, and that you need to gradually withdraw them. You cannot suddenly stop them. The other one that came out in quite a long time after they've been introduced to clinical practice, if you co-prescribe an SSRI with something like an NSAID, you actually further increase the bleeding risk beyond that just of taking the NSAID. And I don't think anybody fully understands why that happens, but it's absolutely a real factor. So if you look in the BNF, increased risk of bleeding is listed as a side effect. Let's just bring back.
Because in my head, I thought it was because serotonin activates platelets.
It may be. It may be that. Yeah. I'm just expressing my ignorance. It could well be related to that. Yes. So that would be a very nice pharmacodynamic interaction, wouldn't it? Well, no, it's not very nice. Very unfortunate pharmacodynamic interaction.
But neat for remembering it.
Yes, yeah. So obviously you've got to look at the side effects. Here they are. These are for escitalopram, but they're very similar for all. This is for all SSRIs, and you can see that they're not without side effects. And I think it's
so many of them overlap with the symptoms of depression and anxiety, don't they?
They do. They do indeed. Yes.
And so, how you pull these apart, I'm amazed. How that's done, really.
Yeah. I have had patients who've gone on them, and actually, the side effect they got was just yawning, just persistent yawning all the time.
Mm. Yeah, and arthralgia is a completely unpredictable one, but you definitely do see it as well.
Yep. So they do have side effects. And of course, you've got to be careful because of this withdrawal syndrome. Right, let's come back to screen. So we've had a brief discussion about benzodiazepines and said maybe in acute stress disorder they could be used for a very short period of time. So how do benzodiazepines work? Can you guys remember from PBL how benzodiazepines work? Come in on the chat stream and let us know what you think. While you're thinking about that, benzodiazepines are interesting. If you go back in medical history, one of the big drugs that was used both to help people sleep at night and as a general anxiolytic, of course, were barbiturates. And I think I think people believe that a lot of people who took barbiturates obviously died because they were very bad in overdose. Famous people, I think Marilyn Monroe, I think was a suspicion that she took barbiturates as an overdose when she died. So benzodiazepines were developed and they were thought to be so much safer than barbiturates. So they came in and almost replaced barbiturates completely, particularly as hypnotics and for anxiety disorders. And if you go back to, I think, the 60s and 70s, a lot of people were chronically taking benzodiazepines to help them sleep or just to take the edge off. And of course, we didn't at that time know that they were addictive. But in fact, we now know they're very addictive. In fact, it's probably more difficult to come off a benzodiazepine long term than it is to stop smoking, because they're so muck with your neuropharmacology. So we've got a few answers. Yeah. So increased GABA, GABA analog increases the inhibitory effects of GABA, leading to hyperpolarization of the cell and inhibitory effects of GABA. Absolutely, guys. You guys are spot on. Well done.
Yes, what I like about that series of answers there is that they've got closer and closer to the accurate answer. Oh, isn't it? So at first we're saying about increasing GABA, and then we're saying, is it a GABA analog? And then, but are we saying that it binds to the GABA receptor and then potentiates the effects of GABA?
Yeah.
And so it's nice that we've sort of built on it as we go down the list.
So obviously what GABA does is effectively it facilitates the transfer of the chloride ion into the cell, and then transferring the chloride ion into the cell, it reduces the chance of depolarization of the cell. So it has an inhibitory effect. And it's very interesting if you just look at this particular picture, and you can see here we've got the GABA binding sites, and you've got the different subunits of the pore. But also on these areas, you've also got binding sites for the benzodiazepines. You've got the binding site for flumazenil, which is the competitive inhibitor of benzodiazepines. You've got the binding site for zolpidem as an example of a Z drug, one of the newer hypnotics. And then, of course, further down in the chloride channel, you've got the binding site for barbiturates that I just mentioned, which were the pre-runner to the benzodiazepines. So it's really interesting, isn't it, that you've got these different sites, and therefore effectively you can create a situation where the cell is resistant to depolarization. The other thing that's really interesting, I find, is some of the more modern theory about these receptors. And of course, receptor theory has evolved. And now there's a lot of stuff actually related potentially to quantum mechanics related to receptor functionality, which gets me really confused because I don't fully understand quantum mechanics. But you've effectively got the benzodiazepines, and they modulate the GABA A receptor. But they're, as we showed in the previous diagram, they're quite distinct from it. And what you do is you get conformational changes. So you end up that the chloride channel can actually, I think does it remain closed? It says remain closed there. Is that the right term? Yeah. Yeah. So you can actually change it. But there's some interesting theories here around quantum mechanics. Have you read any of that, Richard, at all about receptor theory and quantum mechanics?
No, I haven't. No. So just one thing to add, that also alcohol binds to the GABA receptor as well, just to sync that in there as well.
And of course that's very important, because when one withdraws from alcohol, one of the primary initial treatments is to use a benzodiazepine. Otherwise you end up with the cell depolarizing and you end up fitting or extremely anxious in alcohol withdrawal. Yeah. Okay. So I'm trying to use this, but the useful effects of benzodiazepines is sedation, because you overall, it's a general depressant drug. So you reduce the sensory input to the RAS. You can actually induce sleep at high drug concentrations. So obviously you can use them as, if you use high enough dose, you can put people to sleep. They have this benefit of antegrade amnesia. So if you give somebody a benzodiazepine, then you can do things to them and they won't remember. I think in terms of conscious sedation using benzodiazepines, that's very useful if you're having something like an endoscopy or a colonoscopy, or maybe a tooth extraction under conscious sedation. But that also means they can be drugs used for criminal activity. So what criminal activity are benzodiazepines used for? Anybody want to come in? They come up in the press quite a lot, these events. While you're thinking about that, they're also very useful because they can be used as an anticonvulsant activity as well, because they're general depressant. You're less likely to get depolarization and nerve transmission, which is useful, and that's where lorazepam is used in status epilepticus, and also they can be used. Yeah, let's get spiking. They can also be used at low dosage to help in things like if you've got multiple sclerosis with lots of muscle spasm, you can reduce muscle tone using benzodiazepines as well. But that's usually done with very low dose. So yeah, Lily says spiking. Yeah, so this is using benzodiazepines to spike drinks, and then people don't remember what happens to them. In fact, I think one of my ex-colleagues, not from Hull, but from a job many years ago, he reckons that he was robbed by somebody putting a benzodiazepine in his drink at a foreign medical conference. And he woke up in his hotel room with no recollection and no wallet. Has no recollection at all about what happened to him. So yes, so it's very bad. That's why you should never leave your drink unattended, and you should never take a drink from somebody you don't know very well. I think, sorry, I'm sounding like somebody's father here, aren't I?
Yeah. There's a little bit of life advice there, as well as learning your pharmacology.
Yeah. So actually, if you're going to have a colonoscopy, having a bit of conscious sedation is probably a good thing because you don't remember it. But they can also be used very bad by very bad people. So now let's switch a little bit and talk about acute behavioural disturbance. One of the things I found most challenging as a junior doctor when I was equivalent of an F1 was managing acutely disturbed patients who may be acutely delirious or very agitated on the wards, and this sometimes happens after surgical operations. You've got somebody you got staples in, and I remember one occasion, a man becoming so aggressive post-operatively that when I walked onto the ward, all the nurses had blue biro across their dresses. And he'd got hold of a pen from a nurse, and none of them could get near him because he was using it like a knife to try and attack them. This is an old man who'd had a major operation. And we had to actually go in and sedate him for his own safety because we could not talk him down. and literally all of them were covered in pen, and nobody could get near them. So you may well have to deal with situations like that as a junior doctor, and therefore understand how you can safely control that situation. Now, we try and avoid pharmacological approaches, if at all possible these days, because there's a big risk behind giving drug-related rapid tranquilization. But it is used on psychiatric units, often supported by quite extensive guidelines.
Yeah, and just to add that on a medical ward, if someone's acutely confused, the first thought for you as a doctor should be, why? And so, the classic things would be they're in pain, or there might be a new infection brewing. If they're post-surgical, is there some sort of surgical complication? Is there anastomosis leaking? You need to think of these things and not just the nurses want me to get this patient asleep.
But sometimes you've got to sedate them to be able to assess them.
Yes, yeah.
Yeah, it can be very difficult. I think in that situation, when as a junior doctor, we were left to it. These days, I would suggest to you, if you're in that situation as an F1, I think you should get your registrar, because actually it can be quite a difficult situation to handle. Would you agree with that, Richard?
Yeah, then it definitely can be. Also, it's one of the examples where, like, doctor as a leader is a really important thing, isn't it? Because it can be very stressful for all the nurses on the wards, and everyone can be quite upset and worried. And so, coming in and trying to be as confident and clear as possible in your communication and is a really important thing. There's a lot of sort of so-called soft skills that go along with that as well.
Absolutely, I agree with that. So what would you do in this situation? You're on the inpatient mental health ward. You've got a very acutely confused and aggressive patient threatening to hit staff and lashing out at them. What kind of things could you do if you were the junior doctor in the unit and you've been called to help? Would you jump straight to using a drug? What do you all think? I hasten to add, we don't taser people in hospitals. Not a good idea. Let's have a look. So, yeah, try to verbally. Yeah, absolutely, Finley. Yeah. So, medical tranquilization should be avoided. But you may have to intervene if there's a threat to their own health or well-being, to anybody else's safety, and you may need to use pharmacological intervention. In this scenario, we would use a benzodiazepine first line. Most local health, mental health communities have their own localized guidelines for this, so it's worth having a look at them. But when you look at the options available, you've got to have properly trained staff with the right equipment, because as soon as you start restraining people, people can get injured. If you rapidly tranquilize people, then you've got a risk to airway, you've got a risk to cardiovascular support, and you've got to think about it, and you've got to protect the patient and the other staff.
Yeah. So, and a classic situation where you can cause harm here is, giving a big dose of a benzodiazepine to a little frail lady and then walking away and leaving her in bed with a dodgy airway. Just to really quickly mention, I had a pharmacy sort of professor in the past who said, and this is who basically said, "Oh, benzodiazepines, they're not dangerous at all." They were talking about on mice, and they said the only way to hurt a mouse with benzodiazepine is to crush them with the pill box. And but that is actually completely, I've found in practice, definitely not true. It might be true for mice, but not true for humans. And benzodiazepines are quite dangerous drugs. for example, in those reasons. And another case would be, for example, a patient with COPD who says, "Oh, can you just give me something because I can't sleep because the ward's too loud," or something like that. And you give them a benzodiazepine, and then in the morning they're barely rousable and in type 2 respiratory failure. So just be aware of those things.
I wouldn't give them a benzodiazepine.
Yeah, no, definitely not. No.
I had a patient on acute medicine who, it wasn't because they were confused, they actually had some fits, and they were given lorazepam, which is a benzodiazepine, for their acute fitting, and they were given that in the ED, and they were a little old man, and they were given the maximum dose. And he turned up round in the acute medicine unit, went to assess him, and I did his respiratory rate, because I always believe in doing these things myself, because I don't trust the nurses to do all the observations. So I always like to repeat them. So I did it myself, and his reps came out as 2 breaths per minute. So I didn't believe myself, so I counted it again. So I stood there for another 30 seconds, and it kind of went, big gap, 1, big gap, I'm getting a bit sweaty at this point, 2, no further breaths in the 30 seconds. So we got the anaesthetist, and he had to go to ICU for ventilation, because if we tried to reverse his benzodiazepine with flumazenil, he would have probably gone into a status epilepticus. And if we left him, he was probably going to stop breathing. So don't believe this idea that benzodiazepines are safe. At the wrong time in the wrong person, they can be quite dangerous. So that he was as obtunded as if he'd been given an opiate. He survived, he was fine after that. But yes, and there's also a reason why you should always reassess the patient yourself. Don't just copy the nurse's observations. So you've got a variety of different things. You can de-escalate, which is the optimal way, and try and get people into a quiet environment, de-escalate, remove them from any place where they could harm themselves. But if you need to do rapid tranquilization, because the trouble with physical intervention, people can get injured with physical intervention. And if somebody's very acutely agitated, it can take many people to restrain them. I have another case where an elderly man with acute delirium on an elderly care ward in Hull Royal actually ripped an old-fashioned cast iron radiator off the wall and threw it at the nurses. We had another patient quite a few years ago who was acutely delirious post-op, and he went into the day room and he smashed a glass panel which had books behind it and he took the glass and he cut his leg wound open with the glass, and then just bled all over the carpet. So patients with acute delirium can be very difficult to manage at times. And if you try and restrain somebody holding glass like that, you're going to get in trouble. It's going to be difficult. So very challenging situation sometimes. So rapid tranquilization is usually either with IM, lorazepam. Okay, let's ask you the question: why would we give it IM and not IV? Think about the scenario. Visualize it in your mind. Why would we give myself out the way IM rather than IV in this scenario? Surely IV would work much quicker. May pull out an IV. Well, first off, most cases they may not have an IV, particularly if they're in a mental health unit. Why would they have an IV cannula in? Yeah, it's quicker and it can't be ripped out. Yeah. So you're not going to get a cannula in. So the idea is you're going to probably have to do an element of physical restraint, and you're going to have to inject IM, usually into the leg, or I would imagine it's usually the leg, isn't it? We'll get IM into outer part of the thigh. Alternatives are IM haloperidol, which is a major tranquilizer, plus potentially promethazine, which is an antihistamine. But you've got to be careful here, because if this is a mental health unit, what other drugs has your patient been on? Because haloperidol will increase the QT interval. So if they're naive to any antipsychotic drugs, or if you don't know what their antipsychotic drug history is, my mistake there, or if they've got cardiac history or they've not had an ECG done, then you're going to go for lorazepam as a safer option. But if you know they've got a normal ECG with a normal QT interval, and everybody in a psychiatric unit who's on antipsychotics will have had an ECG done, then you could potentially use IM haloperidol as an alternative. Have you ever done this, Richard?
Yeah. I've never used promethazine, but haloperidol and lorazepam I have used. And you go through stages of reading the latest guidelines and thinking, oh, maybe I should be using something like olanzapine.
Yeah.
And then you read about olanzapine and then you think, well, actually, come to think of it, maybe I'll go back to lorazepam. And it's funny how quite often you just end up back at lorazepam again, which, as you say, is, even though it does have its risks, at least it doesn't have the potential cardiotoxicity that the other drugs do.
It's, in a worst case scenario, it's much easier to support ventilation than it is to restart somebody's heart. In worst case scenario, which is why lorazepam is safer. The olanzapine is sort of a third line that can be used, but again, you've got to know about things like the QT interval and prior antipsychotic drug use. So if you use haloperidol, you then can't really go on and use olanzapine, is my understanding. Okay, so you've got to be careful. If you're going to rapidly tranquilize, you've got to then be prepared to monitor for the risks, particularly loss of consciousness and respiratory depression. If you've got patients who may be on other drugs, and one in particular is clozapine, you can actually get cardiovascular collapse. For the antipsychotics, it again is cardiovascular and cardiorespiratory complications. And then you can also get dystonia and rarely neuroleptic malignant syndrome. So you just need to be aware of what happened. You can't just do this and then walk away. So you've got to monitor the patient very carefully afterwards to make sure they're safe and have them in a safe place. You know, if you're doing this particularly on a mental health unit, the nurses may have they're not medical nurses. Many mental health nurses these days have gone straight into mental health nursing. They haven't done general nursing. So you, as the junior doctor on the mental health unit, are really the only medical expert there.
Yeah, and they have very little supplies as well. So they have, sort of like one cannula and a single bag of fluid and things like this. So it can, if things go wrong, it can be very difficult.
Well, I remember when we were preparing for COVID, and I was doing some training for the psychiatrists on how to manage COVID on if they needed to have patients kept in a secure unit. And they were actually shipping in additional oxygen cylinders because at any time, I think the whole of Humber mental health unit up near Castle Hill, they actually only had one oxygen cylinder on the whole of the hospital site normally. So, and I think that was on the arrest trolley that they had. So yes, then the facilities for medical care within a mental health unit are very, very low. So let's just switch tack now and talk about drug dependence for a period, because we need to keep going. This is Amon.
You're the one who did it.
I know I am. I know. Amon. There we go. He's a 47-year-old man brought to the ED confused and agitated. So he has a history of alcohol misuse and had not had an alcoholic drink for 48 hours. So he decided he'd had enough and he was just going to stop. So he stopped drinking. Now he's now been hallucinating, and his past history includes gout, for which he takes allopurinol and ibuprofen when he needs it. He has no drug allergies. This is his A, B, C, D, E, so his airway is patent, rests a little up at 22, SATs are okay in room air, chest is clear, he is tachycardic with a regular pulse, he does have a high blood pressure, his glucose is normal, he's 14 out of 15 on GCS because he's confused, and he is sweating. He's got a very marked tremor, and his temperature is borderline elevated at 37.6. He's clearly hallucinating, and he's telling you that he can see ants crawling up the wall. and they're all over him, and he's shrinking away from you to try and get away from the ants. He's trying to get off the trolley, and is also complaining of a bit of upper abdominal tenderness. So what would be your differential diagnosis? And I want 3 because, as we've been trying to say to you, yes, I know this is probably alcohol withdrawal. And you and I know that. I mean, you don't need to have any medical training to know that. But don't always assume it's the most obvious thing. What else could it be? So come in with maybe 2 other. Yep. Tilwa. Is that Tilwa? We'll call you Tilwa. TLL. So, Korsakoff's, okay. Cholecystitis, okay. Do you know, I like that because it would be unusual to get somebody to that level with cholecystitis, but maybe he had cholecystitis that has precipitated him deciding not to drink alcohol because maybe he's feeling abdominal pain. So yes. Wernicke's encephalitis. Okay. Richard, Wernicke-Korsakoff. 2 different things, 1 thing, on a spectrum?
Yeah, I think probably best to think of them as 2 different things, really. But they do, so untreated Wernicke's, and it's not, well, I wouldn't call it encephalitis, it's encephalopathy.
Absolutely.
And if untreated, does then lead to the chronic condition of Korsakoff's. But so just to clarify, so Korsakoff psychosis is, it is not an acute presentation. So it's this, the patient won't be sweaty and tachycardic, and they'll just be sort of confabulating, and they might have associated delusions and things going on, but it's more of a like a chronic subacute sort of psychiatric diagnosis, whereas a Wernicke's encephalopathy is more of a medical acute diagnosis of the ataxia, ophthalmoplegia, and delirium as the classic triad.
Usually get very marked nystagmus and things as well with it.
Yeah.
I mean, Korsakoff, people with Korsakoff can be charming because they confabulate. They just tell you stories and they just fill in the blanks because they have no memory. So this wouldn't be a presentation of Wernicke-Korsakoff in any way. Now, we might need to protect him from getting Wernicke encephalopathy, but that's not the precipitant in this scenario. So I do like the fact we've got acute pancreatitis there. Lily's come in with hyponatremia. And then, of course, as the fact that he's an alcohol misuser, I think Amber's saying also, what about other drugs? What about amphetamine or ecstasy? I like the idea that you're thinking outside the box, because I think that's really, very important, because what it's saying is, don't always just take things on surface. The very first patient I ever saw in Hull Royal when I was a new consultant, I went in to do a ward round with this guy, and he'd been admitted to the acute medical unit, having collapsed at home, being found at the bottom of the stairs, and when he was taken in, he smelled of alcohol, and the ED guys decided that he was drunk, and he was confused because he'd taken alcohol. So they admitted him to medicine. When I went to shake hands with him in the morning, he couldn't. He lifted his shoulder like that, but he couldn't lift his arm. He had a bladder that was up beyond his umbilicus, so he was like 20 weeks pregnant sized bladder. And he had no, he couldn't move his legs. And in fact, what he had was, he'd had a drink. What he had was, he'd actually broken his neck and transected his spinal cord, and it hadn't been detected in the ED. And because he was drunk at the time, they basically decided that was the reason why he was unconscious. So they moved him up to the medical ward. And they missed the fact he had a broken neck. And he was tetraplegic. And in fact, it turned out he'd actually fallen down. Yes, he'd had a drink, but he'd also fallen down the stairs and broken his neck. So just because somebody has got alcohol on board or has a history of alcohol use, please think of everything else as well. And in fact, they the most difficult patients to assess because the alcohol gets in the way. So I do like the fact you've given lots of other reasons. I think that's really important. Full history, proper clinical assessment, do the right investigations, and don't just assume it's all alcohol. Good.
Yeah, and we'll come to toxidromes at the end of this presentation. So if when you do your full examination, you'll if it doesn't fit, with what you're suspecting, then you need to think again. So yes, that's really good.
So let's move on. So we put alcohol withdrawal, alcohol acute delirium secondary to an infection. We also put down possibly acute encephalitis, which none of you guys put. But of course, you could have a herpes simplex encephalitis. That's another option for acute confusion in an adult. But there are often other ancillary features that go with these. So let's look at the mechanism of dependence. It's quite complicated. And in reality, it's all related probably and linked in to some extent also with depression. But you get the sort of acute pleasure and reward elements. But then you also get influences on this compound, which is called brain-derived neurotrophic factor. And you get then chronic neuroadaptive changes, which cause dependence and lead to withdrawal effects. So, the classic ones you think about, of course, are things like cocaine and amphetamines, opioids, alcohol, and also cannabinoids. But of course, you could also, in some ways, add on to this benzodiazepines, I think, couldn't you?
It's funny when not long ago people used to say cannabinoids are not you can't develop dependence. But I think sort of in clinical practice you definitely can. But I've definitely had loads of people say you can't.
Yeah, I think you can. Yeah. So let's look at the management of alcohol withdrawal. So alcohol withdrawal, you've got to be worried about the onset of delirium tremens, which can actually be lethal. What's really interesting is it's quite hard. It's very unpleasant to withdraw from opioids. Very unpleasant. But actually, you're not likely to die. Generally, people withdrawing from opioids will not have a risk of death. They'll feel very unwell, but they won't die. You can die of DTs. So actually, alcohol withdrawal is more dangerous than withdrawing from heroin. So you need to think about who needs to be hospitalized. And I've just given you the figure here, just to remind you. And as Richard has said about the alcohol binding to GABA, the GABA receptor, there's the ethanol binding site. So giving back a benzodiazepine to replace the inhibition you were getting from the alcohol is a good way. So this is a guide to who to admit. We're not going to go through it in great detail, but basically if you're at all worried about them, you get them into hospital. And one of the drugs that's used is chlordiazepoxide, which is a benzodiazepine. So why might we use chlordiazepoxide rather than, say, temazepam or lorazepam that we use for acute seizures or acute tranquilization that we discussed earlier on? Why would we choose chlordiazepoxide for alcohol withdrawal and not choose lorazepam? While you're thinking about that, I'll just keep talking about this. And what you can do is you can do scoring systems. And depending on the score you get on the scoring system, then you can decide on how much chlordiazepoxide you're likely to need to ease the symptoms of the alcohol withdrawal. And then what you do is you start at a high dose, and then over a number of days, you gradually bring down the dosage of the benzodiazepine and you wean the patient off. So what's the difference between lorazepam and chlordiazepoxide at simple level? Think of it from first principles, but what you're trying to do when you give lorazepam when somebody has a seizure versus what you're trying to do when you give chlordiazepoxide when somebody's withdrawing from alcohol. Use that as the thinking. So I'm still waiting for somebody to come in, tell us. So here's an example of a reducing course of chlordiazepam epoxide. Don't remember any of these dosages, but you can see if you're somebody that's drinking 60 units of alcohol per day, this isn't weekly, this is per drinking day. So 60 units. Remember, the normal weekly recommendation is no more than 14 units for an adult per week. So it's less potent and or addictive. Okay, well, that's a good idea. Not the answer, though. Not the answer. It's a pharmacological answer, which I suppose yours is as well, but I'm thinking more of pharmacokinetics. So the idea is you start at a high dose and then gradually you reduce it. Longer half-life, Amber, absolutely spot on. So chlordiazepam epoxide has a long half-life, whereas lorazepam has a relatively shorter half-life. So lorazepam you want to give, terminate the event, control the situation, whereas in chlordiazepam epoxide, because this person's withdrawing from alcohol, you need to maintain a continuous effect of the drug over time. So you want it to have a long half-life.
But yeah, it's just worth mentioning that the onset of action it takes about an hour for chlordiazepam epoxide. So if someone's really acutely withdrawing and really distressed, then giving them some lorazepam can be appropriate because it has a quicker onset.
Yes. That's a good truism, isn't it? Drugs with short half-lives have quick onset. Drugs with long half-lives have delayed onset. It's an important thing. Okay, so you just need to also think about the risk of Wernicke's encephalopathy, which, as Richard said, is an acute medical emergency. So what we generally will do is give a drug called Pabrinex, which is the yellow stuff that smells slightly of yeast that you see hanging in the medical wards, and that's basically thiamine and multivitamins. And the thiamine will protect you from Wernicke's encephalopathy, which is manifested, as Richard said, by confusion and ataxia, memory disturbance, and ophthalmoplegia. And quite frankly, they get quite a lot of nystagmus.
Yeah, I think you'll see this prescribed wrong a lot. This low risk, high risk, and established Wernicke's. In practice, I see that most alcoholics that come in end up getting 2 pairs 3 times a day.
Yes.
Which is, I mean, the thing is, I suppose it won't really cause harm, but it's just unnecessary and I suppose wasting nurses' time and wasting money.
But to be fair, I think that's what most people actually have done, Richard. That's my observation as well.
So it's interesting to look back at the guidelines and see actually a lot of the time we can be giving a lot less of Pabrinex.
Yeah, it's also got vitamin C in it, hasn't it?
Yeah, lots of vitamins.
Lots of vitamin C. Let's just kind of trying to bring it up for side effects. 1 second. Doesn't have side effects now. It's okay. It's very interesting, actually. Let's bring up the BNF for a sec. So this is the entrance. This is for Pabrinex. And it's got basically thiamine and vitamin C. But what's interesting is it doesn't have any side effects, which is interesting. Yeah. Although if you click on thiamine, again, no side effects. There you go. Not often you find drugs in the BNF, or what's defined as a drug in the BNF, that has no side effects listed. Interesting. Right. Okay. So you've also got to think there's lots of other symptoms that may occur with alcohol withdrawal. Sleep difficulties. Again, hopefully the chlordiazepam epoxide will cover that. But you can also asymmetrically dose the chlordiazepam epoxide, so you give a slightly higher dose before bed. So as you're titrating down, you leave the bedtime dose slightly higher than the morning doses, or the early part of the day doses. You can also treat nausea with antiemetics. They sometimes get diarrhea, so you can use loperamide. If they're itching, check them for liver problems, and you can use paracetamol. But obviously, if they've got liver disease, be very cautious with that. And they need support and counselling and referral to the appropriate mental health services. So I'd asked this question earlier on, but I put this in just to highlight some pharmacology. So we spoke about the difference between lorazepam and chlordiazepoxide, and you've got this onset after oral dosing. So it's basically half an hour to 1 hour for lorazepam versus 1 hour or more for chlordiazepoxide. But you can see the difference in elimination, 30 to 100 hours for elimination half-life compared to 10 to 14 hours for lorazepam. So drugs with shorter half-lives have quicker onsets of action. That's a pharmacological truism. Actually, I think we underuse diazepam these days, Richard, because diazepam is actually quite good because it can be used as an alternative to chlordiazepoxide and actually has quite a rapid onset of action, but with quite a prolonged onset. You've got to be a bit careful in the elderly. Right, let's just switch tack now and talk about opioid misuse and withdrawal. So a key thing to remember about is opioid agonists that are used in addiction are methadone and buprenorphine, and opioid antagonists that are used is naltrexone. We don't generally use naloxone in opioid misuse treatment. So when you think about managing somebody with an opioid addiction, and again, I would guide you to go and watch that thing on Disney Plus, Dopesick, because it is actually it's a very good program, and it's interesting to watch, but it also shows people being treated for opioid misuse. I mean, obviously, it's fictionalized, it's sort of semi-fictionalized real life drama. But what you're wanting to do with opioid misuse is create an environment where somebody can be returned to society without needing to use criminality, so they can have a functioning life. And you can live for decades taking methadone successfully and controlling your addiction. So you want to get people back to a productive lifestyle. You want to engage in pro-social behaviors, and you want to try and address underlying problems that's developed, because if you've got somebody with an addiction in the family, whether it's alcohol addiction or opioid addiction, usually that has massive effects. It doesn't just affect the person with the addiction, it affects everybody that's close to them in an adverse way. So what are the differences between methadone and buprenorphine and street opioid drugs? Do you guys know? Have you heard of buprenorphine? Let's see if you can remember anything. Was this covered in PBL in year 2? I can't remember.
I think there is a chap, isn't there, that's on methadone?
I'm sure there is. One of the cases, yeah.
Yeah, because he ends up, doesn't he? He gets HIV, I think, in a later case. Yeah.
So basically, what's methadone? What's buprenorphine? And street opioid drugs such as heroin? What's the difference? Any ideas? Come in on the chat and let us know. You've been very chatty so far, so keep up the good work. Nobody coming in? There is one quite big difference between methadone and buprenorphine. Okay. Yep, so that's good. So Finley and Teelwell have said methadone doesn't give the high that street opioids do, and methadone is longer acting than heroin. Yeah, absolutely. And those are pivotal points about methadone. But let's look at buprenorphine as well. So the key thing behind methadone is that methadone is long acting, so you don't get the high and drop that you get with street drugs. So you maintain high levels of opioid tolerance. You therefore eradicate to some extent the euphoric effect. If you then try and take some heroin on top of methadone, you have less of a euphoric effect. And basically, it works better in an environment. You've got somebody who is still using heroin, then using methadone is the preferred option. and it has a very long half-life, usually administered once a day, which means the individual can go to the pharmacy, they can stand at the pharmacy, and they can be observed to take the methadone. And in doing that, they can, because it has to be observed. Buprenorphine is what we call a partial agonist. So what partial agonist means is that it partially activates, but you get less activation to some extent. So you've got less euphoria and sedation, and you also reduce the risk of fatal overdose. And you get less mental clouding than you perhaps do with methadone. And it does help to reduce the illicit opioid use in long-term treatment. And you can get it either by itself in the form of Subutex, which you may have heard of, or mixed with a little bit of naloxone, which is called Suboxone. And again, this is usually by a sublingual daily dosing. And the addiction services will choose between these in the individual patients, whichever is most appropriate. Naltrexone is an opioid antagonist, and you cannot use it for detoxification. Because if you think about it, if you gave an opioid antagonist to somebody who's heavily addicted to opioids, you're going to put them into a sudden, rapid withdrawal. So in some ways, naltrexone is used where somebody has already completely detoxified and is no longer an opioid user, but they want to remain abstinent, and they then know that if they take an opioid when on naltrexone, it's not going to work, and are actually going to feel quite unwell. So it's in some ways, it's the equivalent of antabuse in alcohol. And in managing alcohol addiction, if you give somebody's completely come off alcohol, you can give antabuse, and then they know that if they then drink while taking antabuse, they're going to become very unwell. Right, let's just talk a little bit about smoking cessation. Just trying to make sure we finish on time. Nicotine dependence is incredibly... nicotine's very addictive, isn't it? So you can try behavioral therapy, which is generally a major way forward. But these days supported often with pharmacotherapy in the way of gums, inhalators, patches. You can also use two other drugs. One is bupropion and the other one is varenicline. And these work partially or fully on the nicotine receptor. So these actually can be good adjuncts to us alongside behavioral changes. It's difficult. I'm a non-smoker. I've never smoked. My parents were heavy smokers, and they've vowed never to be a smoker. But it is very difficult to stop smoking. So let's now switch over to a little bit of fun and talk about toxidromes. And this is a drugs of misuse quiz. So here, try not to look at the next slide if you've got the slides up. So in these slides, what we've got is, along the top is a guide to the different physiological features that you may have. And then below it are these rows in which there are various changes or no changes in each of these physiological parameters. And what we'd like you to do for each of the headings is choose which of these would in particular be likely to be the one that links to the heroin overdose. Now, Richard, do you want to explain what concept of toxidrome?
Yeah, so it's obviously there are times, sometimes a patient will come and say, I have taken this drug, but often they'll come and be non-specifically unwell, and you think that they have taken something, and you need to try and work out what that is to direct your management. And so the toxidrome is the sort of the constellation of here it's signs, but it could be symptoms as well, that that point you towards a group of toxins. And I think something like this, I think, is really helpful, and I think it's quite a high yield thing to know. But definitely, yeah, when you start working, I think it's such a simple slide, and you can learn a lot from it, really. And again, yeah.
We also bring it back up in year 5. So if we look as an example for heroin overdose, what do we know? What do you know about heroin? What would heroin do to your respiratory rate? So it's an opioid. What happens to respiratory rate? Does it go up? Does it go down? Does it stay the same? What do you think, chat? Goes down. Okay, so we can now go and say it's either this one or this one. Right. What generally happens to your pupils with an opioid overdose? Do they stay the same? Do they dilate or do they constrict? Pupillary constriction, yeah. Okay, and what happens to your general energy levels? Do they go down? Do they go up? Or do they not change? Nobody's sure about energy.
Well, I think Amber has
She's come down.
jumped ahead a bit and said it's the third one down.
She has, yeah, but I was trying not to jump straight to the answer. Okay, so yeah, so this is, if you had this clustering, this would strongly suggest to you that this was an opioid overdose. Reduced respiratory rate, reduced heart rate, reduced blood pressure, smaller pupils, reduced overall temperature. Now, it won't be hypothermia, it'll just be down within the normal range. No change in bowel motions, no change in sweating, and generally energy is down, but usually the patient will be unconscious at this point anyway, so the kind of energy is already down. Only thing I would say to you is, textbooks are very good, aren't they, at saying to you, this is the classic pattern. In real life, you might only get 3 of these, and not everyone. I've seen people with heroin overdoses who did not have pinpoint pupils, particularly in the elderly. So you just need to be aware that if you didn't have pinpoint pupils, but if you had all the others, it could still be an opioid overdose. That's the important thing to remember. But respiratory rate is generally a major marker. Okay, what about cocaine? What kind of features would you see in a cocaine use? So throw in some physiological measure. Dilated pupils, says Finlay. Yeah. Increased energy levels. Great deal, yeah. High heart rate. Yeah. Increased sweating. Okay, so I think on the basis of that, what we're saying then is it's most likely to be this one. So cocaine is generally a stimulant drug, whereas opioids are generally a depressant drug. So this is the sort of features you might well get with cocaine. Absolutely right. What about diazepam then? Think about the mechanism of action. So what kind of features would you get with a diazepam overdose? Benzodiazepine. Low respiratory rate and heart rate as its GABA. Okay. So on that basis, yeah, so we're looking at either number 3 or number 5. Any other hints? How would you distinguish it between 3 and 5?
This is an interesting one from what you just said, actually, in terms of
Low energy, yeah. Often would be unconscious, yeah. Normal pupils, okay. And that's what you're hinting at, isn't it, Richard?
yeah. So you can imagine a situation where it might be difficult to tell the difference between an opiate or a benzodiazepine overdose. And in that case, what you do is, so obviously both of these drugs have antidotes, but flumazenil, which is the antidote for benzodiazepine, is a very dangerous drug. And often bad things happen when you use it. So people have seizures, and so it's definitely not one you would be prescribing as a junior doctor. Whereas naloxone is it is a much safer antidote. And so if you're in a situation like this where you've got all these signs and you can't tell about the pupil size, you're not convinced, then probably the best thing to do, Prof. Eppo might have a different opinion, but is to treat it as though it were an opiate overdose, and give naloxone and see if the patient wakes up. And if they do, then that's made your diagnosis. If they don't, then it could be you need to give more naloxone. But then, as the guidelines say, once you've given basically a couple of good doses of naloxone and there's no response, then you review the diagnosis, and actually maybe this isn't an opiate overdose, this is a benzodiazepine overdose. And then, and then you consider whether it would be safe to give flumazenil, or whether maybe you just wait this out and support the airway and the breathing, and wait for it to come out of their system.
Yeah. So I think that's absolutely. I mean, I would do the same. If I had somebody came in who had reduced respiration, reduced heart rate, the BP's a bit low, they're unconscious, and I'm struggling to differentiate the pupils, I would treat with naloxone. And once I had removed naloxone as an option, then you would be thinking this is likely to be benzodiazepine. If we go quickly to the BNF, and I'll show you this section here. So if you look at this bit, I'll just highlight it. There we go. So that bit there. So initially 400. Don't remember the doses. Initially 400 micrograms, then 800 micrograms for up to 2 doses. If no response, then increase to 2 milligrams. If still no response, then review the diagnosis. And that's absolutely right. In my experience, it's very rare for anybody with a heroin or opioid overdose to not respond to 2 milligrams of naloxone. So at that point, you're thinking this is probably benzodiazepine. Now, the problem with overdoses is that many people don't just take one drug. And often if somebody has taken a benzodiazepine overdose, they may well have taken it with other drugs, and which is what you call a mixed overdose. In that scenario, if you give flumazenil, you can precipitate uncontrolled convulsions. And I remember Mr. Jackson, one of my ex-colleagues, saying on one occasion, in the early days of using flumazenil, when we thought it was quite safe, they gave flumazenil to a patient who then went into status epilepticus, and no matter what they did, the patient continued to fit and died. So if you read all of the guidelines, they say that flumazenil should only be used by experienced clinicians in a scenario in which they fully understand why they're using it. I.e., basically, if you're doing an endoscopy and you say you gave midazolam, and it's an elderly patient who you oversedate, and you know all the drugs they're on, you know all their past history, and you want to then reverse the benzodiazepine, in that scenario, it's safe to give flumazenil. But in an overdose environment, in an unknown patient taking unknown drugs, flumazenil is, you just don't give it. And we'll talk about this in year 5 in more detail when you get to that point. So that's your benzodiazepine. So here's a summary slide that sort of generally summarizes it. And you can therefore look at classes. So this top line is generally anticholinergics, which would also include antihistamines, which of course, as you know, cross-react with the muscarinic receptors. Cholinergic is interesting because, of course, this might have been useful to know if you were in Salisbury a few years ago. Why might this have been useful to know if you were in Salisbury? What happened in Salisbury? The medical team were really on the ball that day. Any ideas? Let's see if you read the news. Nobody any ideas? I'll give you another few minutes. While you're thinking about that, let's just talk about opioids here. Sympathomimetics. So things like MDMA, ecstasy, will also look often like cocaine. Novichok. ZZs. Yes, absolutely. Yeah. So Novichok and related nerve agents will cause cholinergic pictures. So they will often give you this situation where the pinpoint pupils, increased bowel movements, and massive over sweating and increased salivation. So they spotted this and they knew they were dealing probably with something, a cholinergic poisoning agent. And, where did you get that from? Well, in the UK, it's very unusual these days because there's a lot of ban on using organophosphate fertilizers. You see this more often in places like India, where they still use organophosphates for fertilizing, and you can get organophosphate poisoning in farmers. But generally, a cholinergic sort of picture would be vanishingly rare in the UK, and hence why they were, I think, very quickly able to switch on to what was going on. And then, of course, sedative and hypnotic at the bottom, generally depressant drugs. It's not just the benzodiazepines, but it could be anything, if this was propofol. I mean, who was it took propofol?
Michael Jackson.
Michael Jackson, yeah. That's right. So, this would have been a picture you would have had in Michael Jackson, I suspect, in that situation. Okay, so we're coming up to past. I've got a couple more slides. This is the one here. This is just to show you, this is naloxone. That's a trade name. And this is a pre-prepared syringe of naloxone. They don't come like this in hospital. We have ampules, which we draw it up from. But this can be given to drug users in the community. And there are now lots of, they get trained and they get shown. And this can be life-saving in the community, where people who are drug users can give it to each other if one of them takes an overdose. And one of the problems with drug use in the community, of course, is you don't know what you're taking. You don't know if it's been cut with fentanyl, which will cause you to die because it's so potent. And there have been a lot of drug deaths related to fentanyl being added to things like heroin or being miscut. And then, of course, in Scotland a few years ago, there was an outbreak of anthrax in drug users because they were cutting the heroin with something that had anthrax spores in it. So there's an outbreak of anthrax. So you've no idea what you're injecting if you're injecting illicit drugs. And of course, so common antidotes, opioids is naloxone. Tricyclic antidepressants, the actual antidote is sodium bicarbonate infusion. For benzodiazepines, it's flumazenil, but only in a medically controlled environment for conscious sedation. And ethylene glycol, which is antifreeze, or methanol, which is wood alcohol that you might drink by accident. There is a specific antidote now called fomepizole. You may be familiar that you used to give alcohol as a competitive, to compete with these for metabolism. But actually this fomepizole is a specific inhibitor of alcohol dehydrogenase and is much better. And don't think you won't see these. A few years ago, there was a couple of boys drank antifreeze and one ended up on dialysis, the other one died. That was in Grimsby. And methanol, I've certainly had a methanol poisoning. Somebody who drank a bottle of vodka, which their father bought at Hull Docks 15 years earlier, He only had one glass of it, but he went and he had methanol poisoning, and we had to give him fomepizole. It took a bit of detective work to work out what it was, but we got there. So these do happen in real life, and you will give these antidotes at different points. Less likely this one, because unless you're an endoscopist or an anaesthetist. Right, that's 10:32, so we've not done too badly, better than Tuesday, see, because we didn't have any glitches. Just remembered about SDL, the learning outcomes from Blackboard. The P drug lists are there as well, and particularly for mental health, don't forget about non-pharmacological therapies. And when you're in block 33, the mental health teams will talk to you a lot about different types of non-pharmacological therapies for mental health disorders. Right, now I'm just going to check when we're up next. I think we've got a half an hour break. Just checking on that. I put up a thing on Blackboard and they moved it. Because obviously I put it in the wrong place. So, yes, so we're next due on at 11 o'clock. So I think it's because we've not run over, we've got a bit more time for a break. So we'll see you back in about 25 minutes at 11 o'clock for the next masterclass. I'll put on the music and I'll leave the exiting board, and I'll post the next masterclass up in block 33 again like I did, the link, and I'll also send another announcement out.
Oh,
yeah.
Sorry, they've just
yeah.
Yeah, sorry.
Okay, so the difference between naloxone and naltrexone, they're both antagonists, but naltrexone has a long duration of action, whereas naloxone has a very short duration of action. If I go back one slide. So when you give naloxone, it's got a relatively short half-life. So it's really good. It has to have a rapid onset. To have a rapid onset, it has to have a short half-life. That's that truism. So you inject it, it works very quickly. Literally, if you inject it, somebody who's got a heroin overdose, they can literally just wake up. Now, your aim is not to wake them up. Your aim is to restore respiration. Because if they wake up fully, it's not needed for their safety. And the other thing is they might punch you because you've just reversed their high. And often they jump off the trolley and they go running out the hospital. Now, the problem with that is generally the naloxone has a much shorter half-life than the opiate that they took that caused their respiratory depression. So they run out the hospital, and about 40 minutes later, the naloxone wears out, but the opiate is still in their system. And because it's a competitive antagonist, as soon as the naloxone's dissipated, the opiate will bind again to the mu receptors. They collapse in the street, go into respiratory depression and die. So naloxone is not good in this scenario for managing addiction. It's an emergency treatment for overdose. Whereas the naltrexone, it has a long half-life, and therefore you take it, it will be continually active. Now, if you haven't got any opiates on the system, it's not going to be doing anything. It'll just be in your system. But if you were then to try and take an opiate, it would block the effect of that opiate, which is why you only use it in people who are not taking opiates to discourage them from trying to take an opiate. So I think that's the way it works, Richard. Anything else you wanted to add to that?
No. Something that I should know, but I don't. So, but it might be useful for the students to find out as well. Is we get these combination medications, don't we? Like oxycodone with naltrexone, and I've always been slightly confused as to what that was about, and whether it was just to try and counteract some of the opiate side effects like constipation, and whether they feel that it has less constipation associated with it.
I think, are they not? Let's have a look at those just for a second. If people are okay hanging on, well, anybody wants to leave, by all means, go ahead and leave, get your break. But we'll just have a look at those. I'll bring them up. I'm not a big fan of oxycodone.
Funny enough, I have to use it all the time. You see, can't use morphine or codeine.
Oh dear. All right. Okay.
it because kidney patients.
Yeah. But, so, for instance, you do get oxycodone with naloxone.
Yeah.
Yeah.
Yeah, but it just seems like an odd thing to do, doesn't it? But I wondered if it was something to do with helping with some of the peripheral side effects.
Well, but it'll also work on the central because both are absorbed, both transferring across the blood-brain barrier. The one drug that doesn't transfer across the blood-brain barrier is methyl naltrexone, which is the methylated form of naltrexone, and that doesn't cross the blood-brain barrier, and that can be used in palliative care for severe opioid-induced constipation, but it's very expensive and has to be injected. So I do think you do get these. I'm just looking at this one with. I think they're mixtures where they're trying to. So, for instance, you get this one. Oxycodone with naloxone.
Yeah.
And one suspects that's trying to create sort of a partial antagonism at some point. I have to say I've never used them, and I'm not really convinced why anybody would want to.
Yeah, well, same. Yeah.
Yeah.
There must be a reason.
Well, if you look at the indications and dose, maybe we should ask Jason Boland. He's an expert in pain management. But okay, one other thing I would say is, I'm going to be very naughty here. I think some drug companies create these combinations as a way of maintaining a patent on their drug and marketing for increased income. But that's me being very naughty. I do know that sometimes you'll see what drug companies do. You understand, guys, the way that a drug works. So it goes through a whole massive hundreds of millions of pounds of drug development costs to get to the point where it gets a license. And then it then has a patent for a period of time. It's on a patent. And that patent will vary a little bit depending how long it took it to get to market. Once the patent expires, other people can make it, like the generics companies, and they can usually make it much cheaper. And therefore, the drug company makes its most income during the years in which their drug is patented. And you can usually not extend the patent. Sometimes what you can do, though, is you can extend a patent by changing the formulation of the drug. So, and this has been done on a couple of occasions where you heard of the term racemic, where you've got a drug that's got two different isomers. And what you find is one is active and one is not so active. The original drug that was produced had a combination of both racemic components. And then what they do is they then filter out the non-active racemic component and have it as purely racemic X drug. And then they were able to get a new patent for that, so they can extend the life of the drug effectively based on the original clinical trials. But at the same time, because they've changed the molecule that's marketed, they can extend the patent and increase their income. But I'm being very controversial here. I've probably been very naughty. But
so look at the marketing.
Yeah.
Marketing is that it reduces constipation.
Yeah. But does it really?
Yeah. Well, it also reduces efficacy as well, I would have imagined.
Does it really? But that was me being very cynical. I don't know what do you guys think? Anybody who's still here, what do you think? Do you think I'm being disrespectful to the pharmaceutical companies? What's your opinion? Nobody's willing to say. They are businesses. They do need to make money. If they didn't make money, they wouldn't develop the next drug. And, it costs you about 200 million or more to take a drug from discovery of the molecule to market. And for some drugs, it's even more expensive, depending on the drug development costs to get it into a formulation that's actually safe in humans. Yeah, but the trouble is, particularly for some of these drugs, they're actually very easy to produce, and it's only the patent that prevents other people producing it. And of course, there's a new development of what they call for the molecular-based drugs, like the insulin analogs, which we'll talk about on the 15th of September, which are genetically engineered insulins, which have been modified at a molecular level through gene manipulation. And they are very expensive to develop and produce. And you've now got companies which are producing what are called biosimilar, which is for for biological molecules, is the same as a generics company producing Ramipril, but not produced by Pfizer. So, who originally produced Ramipril. So it's interesting, isn't it? And those biosimilars cost less to prescribe than the original analog insulin it's based on. So there is this whole. It's really interesting if you read it. There's a good book, isn't it, which is Big Pharma by Ben
Goldacre.
Yeah. That's a really good book. That's a really, really good book if you want to get a grasp for the whole scenario. Anyway, we've chatted for long enough. I mean, you've kept us going. I know you just don't want your coffee, do you? So I'm going to put the music on, and we will be back at 11 o'clock.